2. 1. Disclaimer. I do not own the rights to the images or information provided. This was strictly made for the purpose of studying for boards. Tetraplegia, UMN. See the description earlier in this chapter in Figure 10-1 for a summary of the clinical signs that are observed in the two regions of the spinal cord that involve all four limbs. The following case examples demonstrate many of the various disorders that affect the cervical spinal cord. Case example 10-10 Signalment. 5-year-old castrated male German Shepherd dog. Sam chief complaint. Inability to stand history. The day before this examination, Sam was found recumbent in his pen. He was alert but unable to stand. Examination. Video 10-23 shows the tetraplegia, which is defined as no voluntary movement of any limb when supported and when recumbent. Note the stiffness hypertonia in his limbs when held in a supporting position. Note that the patellar reflexes can be elicited only in the recumbent limb, which is normal in some dogs, and that is why it is necessary to test this reflex in both positions before you consider it absent. Crossed extension occurs in the pelvic limbs. Nociception is intact. Remember that analgesia essentially requires a transverse lesion, and in the cervical spinal cord, this would cause death from respiratory paralysis. Anatomic diagnosis. Focal or diffuse bilateral lesion of the C1 to C5 spinal cord segments. Differential diagnosis. External injury. FCEM. Intervertebral disc extrusion. Neoplasm. Myelitis. Discus spondylitis. Realistically, this acute onset of tetraplegia could be explained by one of the first three differential diagnoses listed. External injury is essentially excluded for Sam by the history. Imaging procedures are needed to differentiate between FCEM and an acute intervertebral disc extrusion and must be done as soon as possible because the latter diagnosis requires immediate surgical treatment. The imaging will also diagnose a neoplasm, which would be an unusual cause of such an acute onset of clinical signs. Myelitis and discus spondylitis would not be expected to cause such an acute onset of such severe clinical signs. Radiography and myelography were performed on Sam. The video shows the intramedullary swelling in the spinal cord within the vertebral foramen of C3. The presumptive diagnosis of FCEM was made. MRI is the preferred imaging modality for this diagnosis, but it was not available when Sam was studied. While hospitalized, Sam remained recumbent but developed the ability to move his limbs in a few days. He was discharged and remained recumbent for 10 days after the onset of clinical signs. The end of the video shows Sam able to stand and walk 3 weeks after the onset of his presumptive vascular disorder. Video 10-24 shows Molly and Snowball, who are both tetraplegic. This is a unique opportunity to observe two tetraplegic dogs, with tetraplegia caused by a diffuse LMN disorder in one and by a focal cervical UMN, GP system lesion in the other. The anatomic diagnosis is based entirely on the evaluation of muscle tone and spinal reflexes. Molly is a gray-colored 11-year-old spayed female miniature schnauzer with a 10-day history of progressive paresis that began with pelvic limb lameness that was initially diagnosed as arthritis. Snowball is the all-white 8-year-old mixed breed, who was presented unable to stand after being struck by a car. She was tetraplegic when presented, but by the time the video was made 7 days later, she had regained some voluntary movement in the left limbs. The anatomic diagnosis in Molly is diffuse neuromuscular disease. See case example 5-1 for a discussion of the differential diagnosis. A presumptive diagnosis of polyradiculoneuritis was made for Molly, and her therapy consisted of nursing care. Molly first began to move her limbs 6 weeks after this examination, and it was 3 months before she could stand and walk. Radiographs of Snowball taken before she was videoed showed no fracture but a possible narrowing of the intervertebral disc between the C2 and C3 vertebrae. Remember, the C2, C3 intervertebral disc space is normally narrower than the others in the cervical vertebral column. Snowball was able to stand and walk 3 weeks after the injury. Be aware that the most common cervical vertebrae fracture is the cranial aspect of the body of C2. Figure 10-32. This may be the result of the physical stress that is placed there, where the dens articulates with the atlas. The latter acts as a fulcrum when flexion of the head and neck is forced. In addition, the presence of two growth plates in the cranial portion of the body of the axis may be a risk factor for a fracture there. See figure 10-34. These dogs usually exhibit extreme discomfort. It is less common for trauma at this site to tear the transverse ligament of the atlas and the dorsal atlantoaxial ligament, resulting in a subluxation. Case example 10-11 Signalment. 13-year-old castrated male domestic short hair, Curtis chief complaint. Inability to stand history. A week before examination, Curtis suddenly developed difficulty walking, which rapidly progressed to recumbency. He had been blind for a number of months due to retinopathy. Examination. Video 10-25 shows the tetraplegia with extensive hypertonia in all four limbs and the pelvic limb crossed extension. Anatomic diagnosis. Focal or diffuse lesion between the C1 and C5 spinal cord segments. Differential diagnosis. Ischemic myelopathy, FCEM, neoplasm, intervertebral disc extrusion, myelitis, discus spondylitis, vertebral malformation, neoplasm, and a compromise of the spinal cord blood supply are the two most presumptive diagnoses. The latter rarely progresses. as did the clinical signs in this cat unless repeated episodes of vascular compromise occurred. FCEM does occur in cats, but the more common cause of CNS vascular compromise in cats is hypertensive vasculopathy. The retina and the CNS most commonly involving the prosencephalon are the most common organs to be affected by hypertension. Blood pressure should be assessed routinely in your examination of cats with any acute CNS disorder. An acute intervertebral disc extrusion is certainly compatible with this history and anatomic diagnosis but is a less common disorder in the cat. The acute onset and focal clinical signs make myelitis caused by the FIP virus or T. gondii unlikely. Disc spondylitis is uncommon in cats and is less likely to cause an acute onset of clinical signs. Vertebral malformations are rare in cats and would not be expected to cause clinical signs at that age. Curtis was determined to have chronic renal disease and markedly elevated blood pressure. No further studies were performed. Curtis was euthanized, and autopsy showed numerous areas in the cervical spinal cord with ischemic lesions. In the absence of any fibrocartilaginous emboli, they were assumed to be related to the hypertension. The chronic retinopathy was also thought to result from the same hypertension. I have also recognized flexion of the neck in other older cats with cervical ischemic myelopathy secondary to hypertension and in one cat with cervical FCEM, confirmed at autopsy. Hypervitaminosis A. Be aware that cats that are continually fed a diet that contains high levels of vitamin A, for example, raw liver, may develop extensive bone proliferation related to synovial joints. These exostoses may become extensive enough to fuse the entire cervical vertebral column, limb joints, and, ultimately, the entire vertebral column. Clinical signs of cervical discomfort and rigidity are common. Neurologic deficits relate to spinal nerve entrapment at intervertebral foramina and compression of the cervical spinal cord. The lesion is obvious on radiography. Case example 10-12 signalment. 10-year-old female Doberman Pinscher. Mary chief complaint. Inability to stand history. Mary had a progressive gait abnormality in all four limbs for a few weeks. In the last week it rapidly progressed to recumbency. Examination. Video 10-26 shows the tetraplegia with severe hypertonia. You can feel this hypertonia just by lifting the dog up and placing her limbs on the floor. Why is the thoracic limb extensor hypertonia not the Schiff-Sherrington syndrome? Anatomic diagnosis. Focal or diffuse lesion between the C1 and C5 spinal cord segments. This is not the Schiff-Sherrington syndrome because the dog has no voluntary movement in its thoracic limbs. The hypertonia and tetraplegia exist because of the loss of the UMN pathways that are cranial to the cervical intumescence and control thoracic limb tone and function. Differential diagnosis. The following diagnoses are causes of progressive lesions at this anatomic site: neoplasm, intervertebral disc extrusion or protrusion, cervical vertebral stenosis C2, C3 meningeal fibrosis, myelitis, disc spondylitis, syringlohydramyelia, progressive compressive cervical myelopathy. Progressive compressive myelopathy is a common cervical spinal cord lesion that is secondary to a primary disorder that compromises the space available in the vertebral canal. These disorders more commonly cause progressive tetraparesis or hemiparesis and ataxia. The following is a brief review of the causes, and examples will follow. 1. Intervertebral disc extrusion or protrusion. This vertebral column disorder was described earlier in this chapter in case example 10-6. The section on thoracolumbar spinal cord disease. In the cervical region, the intervertebral disc between the C2 and C3 vertebral bodies is the most common site where this occurs. Figure 10-33. A chronic protrusion is common in the caudal cervical intervertebral discs, where it results from chronic malarticulation. See the later discussion 2. Neoplasm. This category includes extradural neoplasms such as lymphoma or metastatic neoplasms, including hemangiosarcoma, and intradural extraparenchymal neoplasms such as meningiomas and nerve sheath neoplasms. Spinal cord meningiomas are most common at the C1 and C2 level, in our experience. An intraparenchymal glioma is the least common neoplasm at this site. 3. Cervical vertebral stenosis. There are congenital and acquired forms of this disorder. Congenital cervical vertebral stenosis. Congenital vertebral malformation as a cause of stenosis of the vertebral canal is uncommon in the cervical vertebrae except possibly for the atlantoaxial subluxation seen in the toy breeds, where the dens is absent or reduced in size. However, this may not be a malformation. An occipitoatlantoaxial malformation has been reported in a dog and a cat. Atlantoaxial subluxation. Atlantoaxial subluxation is a dorsal displacement of the cranial aspect of the body of the axis into the vertebral canal because of the lack of the dens. It is most common in the toy and miniature breeds of dogs, or purse dogs. The absence of the dens is caused either by the degeneration of the dens that was present at birth or by malformation, an aplasia in which the dens fails to develop. Most authors refer to this as an aplasia or hypoplasia without any scientific proof. The dens is derived from the ossification center of the axis referred to as centrum 1. Figure 10-34. Intercentrum 1 is the ossification center for the ventral arch, body, of the atlas. Ossification of centrum 1 forms the cranial articular surface of the axis body and the dens. Most dogs also have a very small ossification center, called the centrum of the protlus, that forms the small apex of the dens. This fuses with the ossification center of centrum 1 at 3 to 4 months. Ossification is first seen in centrum 1 at 3 weeks of age and fuses caudally with the ossification of intercentrum 2 of the body of the axis at 7 to 9 months. Intercentrum 2 is a narrow ossification center between the ossification centers of centrum 1 and centrum 2. The latter forms the central region of the body of the axis. A narrow caudal epiphyseal ossification center completes the body of the axis. If centrum 1 fails to develop, the entire cranial portion of the body of the axis that articulates with the atlas would be absent, not just the dens. We believe it is more likely that the dens, which is present at birth, undergoes a progressive degeneration at a few months of age so that only the cranial articular surface of the axis is left to form the atlantoaxial joint. This process may be similar to that of necrosis of the femoral head, which occurs in these same small breeds and is called Lickford disease. The pathogenesis of this disease is thought to be related to the early development of the sex hormones in these small and toy breeds. The normal alignment of the atlas and axis is dependent on the dens and cranial articular surface of the axis being held in contact with the caudal articular foveae of the atlas by the transverse ligament of the atlas, which is attached on both sides of the ventral arch of the atlas and passes dorsal to the dens. The apical and tualar ligaments attach the apex of the dens to the basioccipital bone cranially. In addition, the thick dorsal atlantoaxial atlantoaxial ligament between the dorsal arch of the atlas and the spine of the axis contributes to this joint stability. The clinical signs of a subluxation usually occur between 6 and 18 months of age, but occasionally later. The loss of the dens may precede the subluxation by a considerable period if the dense connective tissue of the dorsal atlantoaxial ligament resists the instability between the atlas and axis. This delay would be much less likely if the cartilaginous centrum 1 failed to develop a dens at birth. The degree of activity of the patient may influence how long the dorsal atlantoaxial ligament is able to resist stretching excessively to cause the subluxation. When subluxation occurs, the cranial surface of the body of the axis rotates dorsally into the vertebral canal. A dog in this situation has an intact transverse ligament that is forced from its normal dorsal plane into a transverse plane as the subluxation occurs. Figure 10-35. A congenital absence of the transverse ligament of the atlas has been reported. The atlantoaxial subluxation is usually first recognized on lateral cervical radiographs by the increased space between the dorsal arch of the atlas and the spinous process of the axis, which appears to project dorsally and to be displaced caudally. Figure 10-36. This increased space is where the dorsal atlantoaxial ligament has been stretched. It may be difficult to observe the lack of the dens on a lateral radiograph because of the superimposition of the wings of the atlas. If the head is carefully rotated a few degrees to create an oblique view, it will expose the cranial articular surface of the axis without its dens. Ventrodorsal or open mouth craniocaudal views may also show the lack of a dens, but care must be taken to avoid excessive manipulation of such a patient in which the cervical spinal cord is already compromised. MRI is especially useful in these dogs because it may determine the degree of gliosis and atrophy of the spinal cord in chronic cases, which is useful prognostic information. With MRI, the relationship of the dorsal arch of the atlas and the spine of the axis is difficult to appreciate. Instead, the subluxation is recognized by the dorsal displacement of the cranial articular surface of the axis and the enlarged occipital-coxal joint complex secondary to subluxation. The clinical signs vary from reluctance to have the head touched through severe neck discomfort and mild tetraparesis and ataxia or tetraplegia. These patients should be handled with extreme care, and all manipulation of the atlantoaxial joint should be avoided. The clinical signs may worsen after exercise, especially if the paresis and ataxia cause a dog to fall and flex its neck excessively. Be aware that if you sedate or anesthetize such a dog for imaging or subsequent surgery, no muscle tone will be present to help prevent neck flexion and further subluxation. Therefore, when sedation or anesthesia is needed, try to maintain the head and neck in extension. Likewise, as the patient recovers from sedation or anesthesia, have an assistant hold the dog's head and neck in extension until it is awake and able to hold its head extended on its own. Remember that no animal can survive a severe cervical spinal cord compression at this level because of the interference with the radiculospinal pathways necessary for respiration. The use of a thick cotton neck wrap for a cast may help avoid causing increased trauma to the compressed spinal cord during your diagnostic manipulations. Realistic treatment requires surgery. Many procedures have been described, and the choice is somewhat dependent on the age of the patient, the degree of ossification of the atlas and nexus, and the surgeon's preference. It must be remembered that the surgeon is often faced with a severely compromised cervical spinal cord, and it is difficult to perform the surgical manipulations that are necessary for repair without causing further spinal cord compression, which may be lethal for the patient. Many of these patients are quite small, often being only a few pounds. Surgical stabilization is technically challenging. As an alternative to surgical stabilization, conservative therapy consisting of exercise restriction, anti-inflammatory medications, analgesics, and external cooptation with a splint may be successful. I have successfully managed some of these patients conservatively for many years for reasons ranging from concurrent disease that precludes anesthesia and surgery to financial constraints of owners. Atlanto-occipital overlapping. Recently, another disorder has been described at the atlanto-occipital articulation that may contribute to the clinical signs of cervicomedullary compression. Atlanto-occipital overlapping was reviewed in a small group of toy and small breed dogs that all exhibited pain related to neck movements. In addition to this expression of discomfort, some exhibited paresis and GP ataxia in all four limbs as well as signs of cerebellar dysfunction in some affected dogs. Atlanto-occipital overlapping refers to the positioning of the dorsal arch of the atlas rostral to the dorsal border of the foramen magnum. The latter may be enlarged or incomplete. This abnormal position is exacerbated by extension of the head on the neck and partially relieved by flexion. Therefore, positioning of these patients during advanced imaging is crucial for the diagnosis of this disorder. Imaging of some of these dogs also disclosed a dorsal displacement of the medulla, medullary kinking, abnormality of the dens, and syringomyelia. This atlanto-occipital overlapping is illustrated in figures 10-37 through 10-39. These are images of a middle-aged Pomeranian with a chronic history of paresis and GP ataxia, which acutely worsened after a fight. The atlanto-occipital overlapping disorder appears to be a component of numerous abnormalities associated with the development of the skull and cranial cervical region in toy and small breed dogs, 15 kilograms, kg. This includes the occipital dysplasia described in Chapter 3. We believe it is inappropriate to compare these malformations with related human disorders, that is, Arnold Chiari, basilar impression or invagination, as the dynamics associated with the posture of these different species are significantly different. What we recognize at the atlanto-occipital region of these small breeds may be a reflection of the overall development of the skull and cranial cervical vertebrae, which has been selected for by breeding in these breeds. Many clinically normal individuals of these small breeds have radiographic evidence of abnormal development of the bones that enclose the cranial cavity without showing clinical signs. Additionally, MRI for other problems in these small breeds may reveal some of these atlanto-occipital abnormalities without apparent associated clinical signs. Acquired cervical vertebral stenosis. Acquired cervical vertebral stenosis has a plethora of names in the literature that refer to the cervical vertebral disorders that are thought to cause the gait disorder seen in large breed dogs that many refer as the wobbler syndrome. You should avoid using this term because any partial cervical spinal cord lesion may cause a wobbly gait. It is our belief that these acquired cervical vertebral stenoses are secondary to osteochondrosis, which is a common developmental bone disorder in rapidly growing large breed dogs and horses. In dogs, it appears to be responsible for two age-related forms of this vertebral disorder. 1. A vertebral foramen stenosis in young dogs and 2. Stenosis secondary to a degenerative disorder in older dogs that affects the vertebral articulations. Vertebral foramen stenosis. Stenosis of one or more cervical vertebral foramina occurs most commonly in young large breed dogs, especially Doberman Pinschers, Great Danes, and Basset Hounds. Clinical signs occur at a few months of age, usually before 1 year. The bone surrounding the cranial or caudal opening of the vertebral foramen fails to resorb sufficiently to enlarge the foramen to accommodate the growing spinal cord. Stenosis occurs at either end of the foramen or on both sides of the vertebral articulation. Figures 10-40 through 10-44. It usually affects multiple cervical vertebrae caudal to C2. The cervical vertebral foraminal stenosis lesion as well as the typical synovial joint lesions of osteochondrosis have been produced experimentally in Great Dane puppies by allowing unrestricted feeding on a diet that gives them a high energy level and a high level of calcium. Figure 10-45. If the clinical signs are recognized early, some improvement may occur if the patient's diet is restricted in its energy giving and calcium levels and the activity of the patient is restricted as well. Surgery is not as good an option when multiple sites of spinal cord compression exist. Degenerative joint disease DJD occurs in the caudal cervical vertebrae, C5, C6, C6, C7, of middle-aged to older large breed dogs, especially Doberman Pinschers. We believe this is the result of chronic malarticulation at these joints that represents the effects of osteochondrosis when these patients were young dogs. The major source of compression in most dogs is the proliferation and protrusion of the dorsal aspect of the annulus fibrosus. Figures 10-46 through 10-48. Other sources include proliferation of the articular processes and their joint capsules, the yellow ligament, and the dorsal longitudinal ligament. Rarely, a synovial cyst may be associated with the joint capsule proliferation. See case examples 10-13 and 10-18 for examples of this disorder. Many names have been given to this lesion, but the most common is caudal cervical spondylomyelopathy. In horses, this DJD primarily affects the articular processes. Occasionally, DJD affects the articular processes of the caudal cervical vertebrae of young adult large breed dogs, causing a dorsolateral compression of the spinal cord. MRI may be quite helpful in recognizing spinal cord gliosis for prognostic purposes in these patients. This is particularly true in dogs with hyperintensity on T2-weighted MR images within the gray matter of the spinal cord. Sagittal as well as axial imaging may be accomplished in these patients. In some patients, the axial images will be more helpful in discovering the degree of compression of the spinal cord. C2, C3 meningeal fibrosis. Meningeal fibrosis is a lesion that is seen in young large breed dogs, especially the Rottweiler, Bernese Mountain Dog, and Labrador Retriever, and is poorly understood. This fibrosis causes thickening of the dura and presumably of the arachnoid and its trabeculations because an associated subarachnoid space diverticulum is common on the dorsal aspect of the spinal cord at this level. Occasionally, a syrinx occurs at the site of compression. Also, edema within the spinal cord caudal to the fibrosis is often seen with MRI. The spinal cord lesion is a compressive myelopathy that is thought to be secondary to the meningeal fibrosis. Surgery is a challenge because of the thickness of the articular processes at this level, and the chronicity of the spinal cord lesion commonly interferes with recovery. Respiratory distress and failure possible after decompression and should be discussed with the owner prior to surgery. The clinical signs exhibited by Mary, the Doberman Pinscher in case example 10-3, are too severe to be caused by syringohydromelia, discus spondylitis, or most infectious myelitis. The latter is also usually multifocal. Focal granulomatous meningomyelitis is unlikely. This presumably non-infectious lymphoproliferative disorder is described in a later chapter. Mary's age, 10 years, would make a C2, C3 meningeal fibrosis unlikely. Imaging studies are needed to differentiate among neoplasm, intervertebral disc extrusion protrusion, and vertebral malformation malarticulation. Myelography revealed an extensive intraparenchymal mass lesion in the C2 and C3 spinal cord segments. Mary was euthanized, and had autopsy. This mass was diagnosed as an aggressive glioma. Tetraparesis and ataxia, UMN, GP, case example 10-13 signalment, 15-month-old male Bernese Mountain Dog, Gus chief complaint, abnormal stumbling gait history. For almost 1 year, his gait had seemed progressively more abnormal. A veterinarian had diagnosed a cerebellar disorder and thought the cause might be cerebellar cortical abiatrophy. Examination. Video 10-27 shows the slight delay in protraction and the longer strides in all four limbs, but they are easier to see in the thoracic limbs. The thoracic limbs appear to overreach or float at the end of protraction before they are placed on the ground. Note the extension in these limbs when they overreach. This is different from the hyperflexion seen in cerebellar ataxia. Tone was increased in all four limbs and the spinal reflexes were normal to increased. Note, at the end of the video, that the significant postural reaction deficits may be determined by hammer walking the dog, which is easier to do in a large dog such as this. Anatomic diagnosis. A focal or diffuse lesion between the C1 and C5 spinal cord segments. This gait is characteristic of a dysfunction of the UMN and GP systems in the cervical spinal cord. The thoracic limb action is often mistaken for a cerebellar hypermetria. In the latter, the protraction is more sudden, causing an abrupt movement and the limb exhibits excessive flexion rather than the extension seen here. Video 10-28 shows a comparison with a 3-month-old Labrador Retriever that has a cerebellar cortical abiatrophy. Note the abrupt, excessive bursty limb movements in this puppy and the joint flexion. Differential diagnosis. For a focal progressive disorder, cervical vertebral stenosis, C2, C3 meningeal fibrosis, discus spondylitis, intervertebral disc extrusion protrusion, neoplasm, syringohydromelia, myelitis. The age and progressive history are most compatible with a cervical vertebral stenosis or C2, C3 meningeal fibrosis. These two disorders are described in case example 10-12. It would be unlikely for discus spondylitis to be so slowly progressive and to not cause some obvious discomfort. A primary degeneration of the nucleus pulposus with extrusion or protrusion would be very unusual at this age in this breed. Unlike the possible findings in the thoracolumbar spinal cord, we are not aware of any neoplasm that is common at this age and at this site. Be aware that both intraparenchymal and extraparenchymal neoplasms do occur in young animals, but they are not common. We have not observed this degree of cervical spinal cord dysfunction with a cervical syringohydromelia. The long course with focal clinical signs would be unusual for an inflammatory disease. No inherited myelopathy has been reported for this breed at this age. Radiography and myelography help diagnose stenosis of the vertebral foramina at the C5, C6 articulation. The owners elected euthanasia, and a compressive myelopathy was diagnosed at this level. The following videos show examples of young dogs with cervical vertebral foraminal stenosis. Video 10-29 shows a 6-month-old spayed female Doberman Pinscher that exhibits the overreaching action of the thoracic limbs, especially as she slowly turns. Radiography showed a mild vertebral foraminal stenosis of the C3 to C6 vertebrae. The dog improved with restriction of her diet and her activity. Video 10-30 shows a 7-month-old Great Dane with an ambulatory spastic tetraparesis and ataxia caused by vertebral foraminal stenosis at the C5, C6 articulation. Video 10-31 shows Kodiak, a 2-year-old castrated male German Shepherd dog with a history of 5 months of a slowly progressive gait disorder. You should make the anatomic diagnosis of a focal or diffuse lesion between the C1 and C5 spinal cord segments. Kodiak also shows decreased range of motion when either thoracic limb is flexed, and both elbows are enlarged because of chronic DJD. He has mild atrophy of the lateral scapular muscles, which could result from disuse associated with his elbow disease or from denervation if his cervical spinal cord disease is more caudal in the white matter and includes the ventral gray columns or the spinal nerves of either the C6 or C7 spinal cord segments. The differential diagnosis for this anatomic diagnosis in Kodiak is the same as is described for Gus in this case example. Radiographs, see the video, show DJD of the synovial joints at the C5, C6 and C6, C7 articulations. The dorsoventral view shows the proliferation of the articular processes medially into the vertebral canal causing a stenosis. Myelography confirms spinal cord compression at both of these articulations. Case example 10-14 signalment. A 5-month-old male Bernese Mountain Dog. Max chief complaint. Abnormal stumbling gait history. For the past month, Max had exhibited a progressive gait abnormality in all 4 limbs. Examination. Video 10-32 shows the similarity in clinical signs between Gus in case example 10-13 and Max in this case example. Anatomic diagnosis. Focal or diffuse lesion between the C1 and C5 spinal cord segments. Differential diagnosis. See the list of disorders for Gus in case example 10-13 and the discussion presented there. Myelography helped diagnose a C2, C3 meningeal fibrosis with a subarachnoid diverticulum. This study is shown on the video. The first myelogram was made after contrast was introduced into the subarachnoid space between the L5 and L6 vertebrae, and the second myelogram was made after an injection of contrast at the cerebellomedullary cistern. MRI is especially useful in making this diagnosis. Max was euthanized, and the diagnosis was confirmed at autopsy. The following videos show 3 more dogs with this C2, C3 meningeal fibrosis causing compressive cervical myelopathy. Video 10-33 shows Reba, a 2-year-old female Rottweiler with a 10-month history of a slowly progressive gait disorder. This dog exhibited the most remarkable thoracic limb overreaching that we have observed with a cervical spinal cord lesion. In contrast to the gait exhibited by dogs with diffuse cerebellar disease, note the marked extension of these limbs as they are protracted. A laminectomy was performed to remove the area of meningeal fibrosis, and Reba improved over the following weeks. Video 10-34 shows Jagger, a 10-month-old castrated male Rottweiler with a 2-month history of a progressive gait disorder that was diagnosed as a cerebellar disorder, and a cerebellar cortical abiatrophy was suspected. The owner requested a second opinion because no reports of cerebellar abiatrophy in this breed had been published. On the basis of your study of this video, you should make the anatomic diagnosis of a C1 to C5 focal or diffuse lesion. Subsequent radiography with myelography helped diagnose a C2, C3 meningeal fibrosis. Video 10-35 shows Clementine, a 14-month-old spayed female Labrador retriever with a slowly progressive gait abnormality for 5 to 6 months, with no evidence of any discomfort and no response to corticosteroid therapy. Note that the deficit in the thoracic limbs is worse than that in the pelvic limbs. 2 examinations as well as MRI of the lesion taken between the 2 examinations are shown in this video. Surgical decompression was performed by removing the caudal aspect of the spinous process of C2 and the laminae of the caudal aspect of C2 and the cranial aspect of C3. The meninges and associated diverticulum were removed from the spinal cord at the surgical site. After several weeks, Clementine recovered from the surgery and improved. Clementine was monitored for a number of years. Clinically, she never showed any adverse effects resulting from the laminectomy and removal of the dura arachnoid. Case example 10-15 signalment. 13-month-old castrated male mixed breed dog, Sammy. Chief complaint, abnormal stumbling gait history. The owner thought that Sammy's gait abnormality had started about 6 months before this examination and had definitely become worse during that period. Examination. Video 10-36. Study this video and make your anatomic diagnosis. Anatomic diagnosis. A focal or diffuse lesion between the C1 and C5 spinal cord segments. Differential diagnosis. See the list of disorders for GUS and case example 10-13 and the discussion that followed. The video shows the radiographs that revealed the mineralized mass that resulted in lysis of the cranial aspect of the spine of the axis and extended cranially over the dorsal arch of the atlas. The myelogram shows the severity of the spinal cord compression at that site. The mass was removed surgically and diagnosed as a stage in drought calcinosis, calcinosis circumscripta, tumoral calcinosis. The dorsal aspects of the atlanto-occipital and atlantoaxial sites are the most common sites of this lesion, but it has been reported at other levels of the vertebral column. After the surgery, Sammy was tetraplegic for several days but made nearly full recovery over the ensuing weeks. Case example 10-16 Signalment. 5-month-old castrated male Rottweiler. Hans' chief complaint. Abnormal gait and difficulty breathing history. When Hans was about 8 weeks old, the owner recognized that his pelvic limb gait seemed abnormal. When he was 12 weeks old, he began to exhibit some difficulty breathing, especially when he was exercised or excited. By then, his pelvic limb gait was worse, and at 4 months of age, he occasionally stumbled with his thoracic limbs. The owner also stated that Hans occasionally lost his meal, and the description seemed to fit regurgitation, not vomiting. Examination. Video 10-37 shows the mild clinical signs in the thoracic limbs, the prolonged stride and mild overreaching when the limb is advanced. The thoracic limb hopping responses are also slower than normal. Note the inspiratory dyspnea that Hans shows during this examination with his gasping for air and the marked abdominal movement associated with contraction of the diaphragm. Also note the sunken appearance of the eyes and the protruded third eyelids bilaterally. Anatomic diagnosis. A focal or diffuse lesion between the C1 and C5 spinal cord segments in the recurrent laryngeal and vagal nerves. Differential diagnosis. For the spinal cord lesion, the differential diagnosis is the same as the 3 case examples that were listed and briefly discussed for guessing case example 10-13. In addition to those, an inherited myelopathy has been reported in the Rottweiler breed. It is associated with a neuropathy that is most pronounced in the recurrent laryngeal nerves, and some of these dogs have a megaesophagus or microphthalmia bilaterally. Hans exhibits all of these features. Inherited encephalomyelopathy polyneuropathy. Inherited encephalomyelopathy polyneuropathy is a preferred term for a disorder first published in 1997 to describe neuronal vacuolation and spinocerebellar degeneration in young Rottweiler dogs and defined as an autosomal recessive genetic disorder. The name these authors gave to this degenerative disorder is, however, incomplete, as it refers only to the most pronounced lesions in the spinal cord. The spinal cord lesion consists of a bilateral symmetric axonopathy with secondary demyelination and astrogliosis, which is most pronounced in the lateral and ventral funiculi. This lesion is not limited to the spinocerebellar tracts. Many tracts are affected, including the UMN tracts, which is why the gait disorder is typical for a dysfunction of the GP and UMN systems. The thoracolumbar segments are most affected, which possibly suggests why the degenerative lesion first develops and explains why the clinical signs are first observed in the pelvic limbs. Vacuolation of neuronal cell bodies is scattered through the spinal cord and brain, with no other evidence of any microscopic abnormality of these neurons. The brains of these dogs test negative for prion protein. A neuropathy is prominent in the recurrent laryngeal nerves and scattered in other long nerves. Denervation atrophy of all the intrinsic laryngeal muscles except for the cricothyroideus is significant. Figures 10-49 and 10-50. The clinical signs begin at about 6 to 8 weeks of age and may start with either inspiratory dyspnea or paraparesis and pelvic limb ataxia. Some of the dogs that first exhibited the signs of laryngeal paralysis had laryngeal tie back surgery to improve their breathing before the clinical signs were first observed in the pelvic limbs. It is paramount that the veterinary surgeon be aware of this disorder and counsel the owner appropriately before surgery. All dogs progress in a few weeks to tetraparesis and ataxia in all 4 limbs. Some dogs develop megaesophagus and regurgitate, and some dogs have bilateral microphthalmia. These small eyes appear to be sunken into the orbits, and therefore the third eyelids become prominent. Horner syndrome does not occur in these dogs. A few dogs have been reported to exhibit clinical signs of dysfunction of the cerebellum or the vestibular system, but this has not been our experience. Other inherited disorders in the Rottweiler breed. In addition to this inherited disorder, at least 6 other presumably inherited degenerative disorders of the nervous system have been reported in the Rottweiler breed. In our experience, the disorder that we have described in Hans, that is, inherited encephalomyelopathy polyneuropathy, is, by far, the most common one that we currently see in this breed. The following is a brief description of the others. 1. Neuroxynal dystrophy is an axonopathy that causes the clinical signs of progressive cerebellar disorder and has an onset between 1 and 2 years of age. 2. Leukoencephalomyelopathy is a primary demyelination that causes progressive cervical spinal cord signs that start between 1.5 and 3.5 years of age. 3. Motor neuron disease causes progressive diffuse LMN signs starting at about 4 weeks of age but does not cause any dyspnea. 4. Polyneuropathy, axonopathy, causes progressive diffuse LMN signs, including inspiratory dyspnea starting at about 2 months of age. Cataracts may also be observed. All lesions are limited to the nerves in these dogs. 5. A distal neuropathy has been reported in mature Rottweilers, with clinical signs of diffuse LMN disease starting between 1 and 4 years of age. Dyspnea has not been reported in these dogs. 6. A Duchenne type of muscular dystrophy, called dystrophinopathy, has been reported in male Rottweilers. This is a progressive, diffuse myopathy that starts at about 8 weeks of age but does not cause any dyspnea. We have also studied a 5.5-month-old male Rottweiler with multifocal neurologic signs, including tetraparesis and ataxia caused by progressive cervical myelopathy. In addition, corneal dystrophy and multiple bone and joint abnormalities all were caused by mucopolysaccharidosis 1. We have recently studied 2 littermate boxers from Western Canada that had the same clinical and pathologic disorder as the Rottweiler in case example 10-16. Case example 10-17 Signalment. A 6.5-year-old spayed female mixed breed, Olive chief complaint, inability to walk history. About 2 weeks before this examination, Olive began to stumble on her right thoracic limb. Over the next week, it became worse, and the left thoracic limb also became affected. At present a Cheyenne, she could not use either thoracic limb. Examination. Video 10-38 shows the disparity in her ability to use the thoracic versus the pelvic limbs. Note the thoracic limb hypertonia and intact spinal reflexes. Nociception was considered normal, as was the cutaneous truncee reflex. Anatomic diagnosis. A focal or diffuse lesion between the C1 and C5 spinal cord segments that affects primarily the central region of the spinal cord. At this level, this specific location in the central region of the spinal cord explains the profound disparity between the more severely affected thoracic limbs and the mildly affected pelvic limbs. Differential diagnosis. Intervertebral disc extrusion protrusion. Neoplasm. Myelitis. An intervertebral disc extrusion protrusion that occurs on the midline through the dorsal longitudinal ligament and compresses the spinal cord on its ventral midline causes the spinal cord to tent over the compressing mass, and the central portions of the spinal cord will be more seriously affected than the peripheral components that are more commonly compressed. Central lesions of the cervical spinal cord cranial to the C6 segment appear to affect predominantly the UMN tracts that are projecting medially to terminate in the ventral gray columns of the cervical intumescence. An extraparenchymal neoplasm at the same ventral midline site could cause the same compression. An intraparenchymal neoplasm that developed in the center of the spinal cord and expanded peripherally is another consideration. Myelitis localized to the central portion of the spinal cord white matter could also cause this anatomic diagnosis. Canine distemperviral myelitis, protosomal myelitis, granulomatous meningomyelitis. FCEM was excluded from consideration because of the 2 weeks of progressive clinical signs. Imaging studies in CSF evaluation are needed to differentiate between the remaining disorders. Myelography MCT with contrast in CSF showed a diffuse intraparenchymal swelling of the spinal cord segments from C3 to C6. Olive was euthanized, and the autopsy revealed this diffuse swelling to be a form of glioma called gliomatosis cerebri, which is a rare neoplasm to occur in the spinal cord. It infiltrated gray matter and adjacent white matter, sparing the peripheral portion of the white matter in all the funiculi. Figure 10-51. Hemiparesis and ataxia, UMN, GP, case example 10-18 signalement, a 3.5-year-old spayed female miniature schnauzer. Tasha chief complaint, abnormal use of the right pelvic limb history. The owner noticed that over a few hours, Tasha became lame in the right pelvic limb. The video was made 4 days later, and the owner thought that Tasha had already exhibited some improvement. Examination. Video 10-39 shows the examination. Anatomic diagnosis. A focal or diffuse lesion on the right side between the C1 and C5 spinal cord segments. You should have recognized a spastic hemiparesis and ataxia of the right limbs and noticed a mild overreaching of the right thoracic limb and a slow hopping. Responses in that limb. The veterinarian who saw Tasha on the day clinical signs first began recognized that both right limbs were abnormal. Differential diagnosis. FCEM, intervertebral disc extrusion protrusion. External injury was excluded because of the history. An intervertebral disc extrusion protrusion would be unusual in this breed at this age, and a lack of any discomfort was more suggestive of FCEM. This is a breed that is at risk for FCEM. The asymmetric clinical signs as well as the spontaneous improvement are most compatible with FCEM. On the basis of this evaluation, no ancillary procedures were performed, and Tasha recovered completely over the following 2 weeks. Tetraparesis and ataxia, LMN thoracic limb, UMN, GP pelvic limb, twingen. Case example 10-19 signalement, a 9-year-old spayed female Doberman Pinscher, healed. A chief complaint, abnormal stumbling gait history. The gait abnormality had been progressing for about 6 weeks. Examination. Video 10-40 shows a difference in the length of stride between the pelvic and the thoracic limbs. This is often referred to as a 2-inch gait. In the hopping responses, I am supporting most of the dog's weight in the initial thoracic limb hopping, which shows a better response than when Hilda has to support all of her weight unassisted. Note the atrophy of the lateral scapular muscles. Note Hilda's tendency to hold her neck slightly flexed and her reluctance to move it freely. Anatomic diagnosis. The C6 or C7 spinal cord segments. The pelvic limb clinical signs are clearly caused by a dysfunction of the UMN and GP systems. The thoracic limb clinical signs are a paradox because the short strided gait and the lateral scapular atrophy are LMN signs, and the marked hypertonia is a UMN clinical sign. The poor hopping responses when Hilda had to support all of her weight suggest an LMN component of the deficit. This mixture of clinical signs indicates a quadricervical spinal cord lesion with involvement of both the gray and the white matter of the cervical intumescence. It is typical for a focal lesion at either the C5, C6 or C6, C7 articulation. Remember that the lateral scapular muscles are innervated by the suprascapular nerve, which is formed by the ventral branches of the C6 and C7 spinal nerves. The denervation atrophy relates to the loss of GSE LMNs in either the C6 or C7 spinal cord segments. See figure 10-47 and 10-48. Differential diagnosis. The most common cause of this anatomic diagnosis, with its unique combination of UMN, GP and LMN clinical signs, is the acquired DJD form of cervical vertebral stenosis. A proliferation and protrusion of the annulus fibrosus is usually the major structure involved in the spinal cord compression. See figures 10-46 through 10-48. This is often associated with collapse of the intervertebral disc space and the development of enthesophytes on the adjacent vertebral bodies. A Doberman Pinscher that is more than 5 years of age is at risk for this disorder. Be aware that a lesion such as a neoplasm in the cranial thoracic vertebrae that causes discomfort may also cause a short-strided thoracic limb gait, but the hopping responses will be normal. Disc spondylitis or a neoplasm of the vertebrae are such considerations. The flexed neck posture and limited movement are commonly seen in this DJD disorder. Significant resistance is commonly shown by the patient to attempts to manipulate the neck, but these dogs rarely exhibit the extreme discomfort often seen in dogs with acute intervertebral disc extrusion. Imaging studies are necessary to further define the clinical diagnosis. See the video for radiography and myelography that were performed on Hilda, the dog in this case example. They show the changes described earlier at the C6, C7 articulation and the associated extradural compression of the spinal cord. Videos 10-41A and 10-41B show Tigger, a 12-year-old male Ibizon hound, at his kennel in Texas. Tigger had a lesion similar to that of Hilda, and it caused a slowly progressive gait disorder. Video 10-41A was made a few weeks after the onset of clinical signs. And video 10-41B was made about 3 months later, just prior to euthanasia. Tigger's tissues were sent to us for study because the owner was a breeder of Ibizon hounds and wanted to make sure that his dog did not have the presumably inherited axonopathy that we have recognized in this breed. This axonopathy is described in Chapter 13. It causes clinical signs within the first few weeks of life. These clinical signs have a cerebellar quality. See Video 10-42 shows Hoosier, an 8-year-old castrated male Dalmatian with a history of 2 months of a progressive gait abnormality along with some discomfort when he gets up and down. Note that Hoosier exhibits a 2-engine type of gait similar to that seen in Hilda. However, his hopping responses in the thoracic limbs are normal. The anatomic diagnosis was cranial thoracic spinal cord segments. The radiographs in myelogram, see video, show a neoplasm within the body of the second thoracic vertebra that is compressing the spinal cord. We attributed the short-strided thoracic limb gait to the discomfort caused by this bone neoplasm. At autopsy, it was diagnosed as a chondrosarcoma. Case example 10-20 signalment. A 16-year-old spayed female domestic shorthair. Izzy chief complaint. Abnormal gait history. Izzy had exhibited a progressive gait abnormality for 6 to 8 weeks. Examination. Video 10-43 shows the 2-engine type of gait. Hopping responses were slow in all 4 limbs, and muscle tone and spinal nerve reflexes were normal. Moderate atrophy of the muscles was seen in both thoracic limbs. Anatomic diagnosis. C6 to T2 spinal cord segments. The short strides in the thoracic limbs are a clinical sign of dysfunction of their LMN innervation. Differential diagnosis. Neoplasia. Intervertebral disc extrusion protrusion. Discus spondylitis. Myelitis neoplasia is the most presumptive clinical diagnosis for this anatomic site at this age and with such a slow progression. Lymphoma is the most common feline neoplasm that affects the spinal cord and usually is an extradural mass lesion. As a rule, it occurs in younger cats. At this age, a glioma is a strong consideration. An intervertebral disc extrusion protrusion is uncommon but is a consideration at this age. Vertebral discus spondylitis is rare in cats. Myelitis caused by the FIP virus or T-Gondii is not likely to remain so focal for this length of time and is less common at this age. MRI showed a contrast-enhanced mass lesion bilaterally associated with the first thoracic spinal nerve roots, with compression of the spinal cord at that level. Figure 10-52. An infiltrating form of lymphoma was suspected. Izzy was euthanized, and had autopsy the bilateral mass lesions were diagnosed as malignant nerve sheath neoplasms of the first thoracic spinal nerve roots. Figures 10-53 through 10-55. This is a rare neoplasm in cats to affect the nerves at the level of the spinal cord. Note the close correlation between the gross lesion and the MR images. Compare this with the neoplasms in figures 10-56 and 10-57, which show a lymphoma infiltrating cranial thoracic spinal nerve roots and nerves bilaterally. Case example 10-21 signalment. A 3-year-old spayed female border collie, Welsh chief complaint. Inability to stand and walk history. Welch was inside her home and was normal when the owners left for work but was found unable to stand when they returned 8 hours later. Examination. Video 10-44 shows the right side hemiplegia and the difference in the quality of the paralysis between the spastic right pelvic limb and the flaccid right thoracic limb. Nociception was normal in the right pelvic limb and mildly hypalgesic in the right thoracic limb. Welch had sympathetic paresis, Horner syndrome, which was visible in the right orbital structures. Anatomic diagnosis. The right side of the cervical intumescence. C6 to T2 spinal cord segments. The gray matter lesion accounts for the marked LM and clinical signs and the mild clinical signs of SAW dysfunction in the right thoracic limb. The white matter lesion accounts for the severe UMN clinical signs in the right pelvic limb. When the patient cannot protract the limb, you cannot evaluate the GP spinal cord pathways. The Horner syndrome could be caused by the gray matter lesion extending into the first three thoracic spinal cord segments and interfering with the right preganglionic GVE sympathetic neurons, or it may be the result of the right side lateral funicular lesion in the caudal cervical spinal cord segments interfering with the UMN pathway for the sympathetic system. Differential diagnosis: FCEM, intervertebral disc extrusion protrusion. Neoplasm external injury was excluded because these signs developed while Welsh was confined to her home. FCEM is the most presumptive clinical diagnosis, based on the sudden onset of the paralysis and no indication of any progression of clinical signs in the limbs on the left side over the 2 days before this examination. A unilateral intervertebral disc extrusion would be less likely at this age in this breed, and the sudden onset of such severe focal clinical signs would be unusual for a neoplasm. Cervical vertebral radiographs were normal, but a myelogram showed a mild intraparenchymal swelling of the quadracervical spinal cord segments that was thought to represent edema or hemorrhage associated with the ischemic myelopathy. No change was observed over the next 10 days, and Welsh was euthanized. At autopsy, the right side of the cervical intumescence felt soft and had a slight discoloration. Transverse sections of the preserved spinal cord showed hemorrhages and softening of the gray and white matter on the right side of the C6, C7, and C8 spinal cord segments. Figure 10-58. On microscopic examination, this gross lesion represented a severe hemorrhagic and ischemic necrosis of almost all of the gray matter and adjacent white matter of the lateral funiculus, with some involvement of the dorsal and ventral funiculi, all on the right side of these spinal cord segments. Figures 10-59 through 10-62. Numerous arteries and veins contained fibrocartilaginous emboli. No recognizable lesions were seen in the first three thoracic spinal cord segments, which suggested that Horner syndrome was caused by the lateral funicular lesion disrupting the UMN pathway of the sympathetic system. Of note, in most instances in which dysfunction of the UMN system occurs, the signs reflect a loss of inhibition, that is, the hypertonia we appreciate in the limbs. However, with the sympathetic pathways, the UMN normally provides facilitation to the preganglionic LMNs. The loss of this UMN on one side results in loss of all sympathetic activity on that side. Horner syndrome was observed, but skin temperature was not measured to determine a higher temperature on the right side of the body to confirm this UMN sympathetic lesion. It has been our experience that cervical spinal cord lesions that result in disruption of the UMN pathways of the sympathetic system are most commonly observed with primary intraparenchymal lesions in the spinal cord and rarely from extradural, compressive lesions. Case example 10-22 signalment. A 5-year-old female Labrador Retriever, Cassie. Chief complaint: difficulty walking history. 5 days before this examination, Cassie suddenly lost the ability to walk normally with the left pelvic limb. That was followed 2 hours later by left thoracic limb dysfunction, and she was recumbent when examined a few hours later by a local veterinarian. This veterinarian also recognized that the left pupil was smaller than the right pupil. Cassie had regained the ability to stand and walk by the time she was referred to Cornell University. Examination. Video 10-45 shows the 2-engine type of gait but only in the left limbs. The left thoracic limb LMN clinical signs are more pronounced than they were in Hildewing case example 10-18. Note the hypertonia in the left pelvic limb and the hypotonia in the left thoracic limb. The pupils were symmetric and normal in size in response to light. No discomfort was elicited on manipulation of the neck. Anatomic diagnosis. C6 to T2 spinal cord segments on the left side. The left pupillary meiosis initially observed by the local veterinarian was either UMN partial sympathetic paresis or involvement of the GVE, LMN in the first three thoracic spinal cord segments. The hemiparesis here has an LMN quality in the thoracic limb and a UMN quality in the pelvic limb. Differential diagnosis. FCEM, intervertebral disc extrusion. Neoplasm external injury was excluded because these clinical signs were all observed by the owner of Cassie in an enclosed environment. FCEM is the most presumptive clinical diagnosis in Cassie, based on the sudden onset, the progression over only a few hours, and the spontaneous improvement over the 5 days before this examination. Cassie's age warrants consideration of unilateral intervertebral disc extrusion. No imaging was done on Cassie, and she continued to improve without therapy. Video 10-46 shows Pepper, a 3-year-old castrated male miniature schnauzer, who exhibited a sudden onset of difficulty using the left pelvic limb. That was followed in a few hours by difficulty in the left thoracic limb. On the initial examination, no voluntary movement was seen in the left pelvic limb. The video was made 3 days after the onset of the abnormality. Note the short strides in the left thoracic limb and the fair hopping when her weight was supported. Pepper is a smaller version of Cassie and has the same anatomic and differential diagnosis, but the lesion involves less of the gray matter than in Cassie because no loss of muscle tone has occurred. I made another interesting observation in Pepper when I carefully evaluated nociception in the limbs and trunk on both sides and found it to be slightly but consistently decreased on the right side. This right side hypalgesia may be explained by the crossing of the nociceptive pathway at its origin in the spinal cord. The interruption of this pathway at the level of C6 on the left caused the right side hypalgesia quadral to this level. MRI showed an intraparenchymal hyperintensity on the T2W images that was limited to the left side of the C6 and C7 spinal cord segments, suggestive of edema associated with FCEM, figures 10-63 and 10-64. MRI is especially useful in confirming a presumptive diagnosis of FCEM because it is non-invasive compared with myelography. Pepper continued to improve spontaneously and made a full recovery. Monoparesis. Pelvic limb case example 10-23 signalment. 6-year-old castrated male golden retriever. Ranger chief complaint. Abnormal use of left hind limb history. Ranger had a 2-month history of progressive but intermittent left pelvic limb gait abnormality. It improved initially on non-steroidal inflammatory drug therapy but now is worse. Recently, the owner noticed Ranger collapsing on the left hind limb. Examination. Video 10-47 shows the left pelvic limb gait abnormality. Ranger is unable to support weight in the left pelvic limb. When walking, the limb is short-strided. When Ranger bears weight on the left pelvic limb, the stifle flexes. Decreased flexion of the left hip is seen. Ranger occasionally stands on the dorsal surface of his left hind paw and the left stifle is slightly abducted. The tail is deviated slightly to the right. The left patellar reflex is absent, and the right patellar reflex is decreased. The withdrawal reflex and cranial tibial response are normal bilaterally. The postural reactions, including the poor placement response and hopping, which are normal when all of the weight is supported in the left pelvic limb, are not shown on the video. Nociception is normal, as is the cutaneous truncee reflex. Anatomic diagnosis. Left L4, L5 spinal cord segments, spinal roots, spinal nerves or femoral nerve. Slight involvement of the left L6, S1 spinal cord segments, spinal roots. Spinal nerves are the fibular nerve to explain the failure to extend the left pelvic limb digits, evidenced by standing on the dorsum of the paw. Left caudal spinal cord segments, spinal roots, or spinal nerves to explain the right side tail deviation. Differential diagnosis. Neoplasia, intervertebral disc extrusion, myelitis FCEM and external injury were excluded because the clinical signs were progressive in Ranger. Given the signalment, progression and focal asymmetric anatomic diagnosis of a neoplasm is the most likely diagnosis for Ranger. Neoplasms affecting the spinal cord in dogs may arise from within the nervous system or outside of the nervous system. In the caudal lumbar location, a spread of neoplasia from the urogenital system to the ventral internal vertebral venous plexus must be a consideration. Intervertebral disc extrusions may be asymmetric or unilateral but often are painful. Myelitis would include infectious causes such as Cryptococcus neoformans, canine distemper virus, protozoal or other fungal agents, and immune-mediated diseases such as granulomatous meningomyelitis. Ancillary studies survey radiography of the lumbar vertebral column and sacrum did not reveal evidence of a lytic bone lesion, enlargement of an intervertebral foramen, or a narrowed intervertebral disc space. MRI showed an extraparenchymal, extradural contrast-enhancing mass on the left side extending within the vertebral canal from the L4 to L6 vertebrae. The mass severely compressed the spinal cord and adjacent spinal roots and spinal nerves, which were deviated to the right side. Figure 10-65. These findings are most consistent with a neoplasm, although a granuloma is still a consideration. The owners elected to treat conservatively with corticosteroids. Multifocal or diffuse paresis and ataxia case example 10-24 signalment. A 9.5-week-old female Cairn Terrier. Puppy chief complaint. Stumbling in the pelvic limbs history. Puppy was from a litter of 3, in which the other 2 dogs were males and were normal. When Puppy was 7 weeks old, she appeared to be stiff in the pelvic limbs when she walked. She often stood base wide and occasionally stumbled with the pelvic limbs. Since then, the pelvic limb gait abnormality had slowly worsened. Examination. Video 10-48 shows Puppy's gait abnormality. Anatomic diagnosis. A focal or diffuse lesion between the C1 and C5 spinal cord segments are multifocal lesions that include 1 or more lesions between the T3 and L3 spinal cord segments as well as the C1 to C5 segments. Also, some involvement of the cerebellum may have occurred. The gait is compatible with a cervical spinal cord white matter lesion. This assessment is based on the overreaching of the thoracic limbs on protraction, with extended thoracic limbs, and on the clinical signs of spastic paraparesis and ataxia in the pelvic limbs. The thoracic limb hopping responses are slightly delayed for a dog of this size and as a result of the hypertonia appear too stiff to be considered normal. Watch the thoracic limbs carefully during the hammer walking, and note the delayed protraction and hypermetric response, with excessive elbow flexion, which suggests a cerebellar disorder. An occasional brief head tremor and a slight balance loss are not shown on the video. These cerebellar signs are very subtle and easily overlooked or considered insignificant. If the initial clinical signs affected only the pelvic limbs, as described by the owner, they may be explained by a diffuse white matter lesion that began in the T3 to L3 spinal cord segments, by the development of the first lesion of a multifocal disorder, or by the initial clinical signs of a focal cervical spinal cord disorder before they appear in the thoracic limbs. Differential diagnosis. The following disorders are considerations for a progressive multifocal or diffuse CNS disorder: infectious encephalomyelitis, canine distemper virus, protozoal agents, T. gondii, and caninum, fungal agents, Cryptococcus neoformans, rickettsial agents, non-infectious granulomatous meningoencephalomyelitis, and inherited enzyme disorder causing a storage disease, globoid cell leukodystrophy. Remember to consider in your differential diagnosis any disorder that may be inherited in the breed of your patient. Globoid cell leukodystrophy, Krabbe disease in children, is a disorder that is most common in the West Highland White Terrier and the Cairn Terrier. It is inherited as an autosomal recessive gene disorder and results in a deficiency of the lysosomal enzyme galactosylceramidase 1, beta-galactosyl-prosidase. Most inherited enzyme disorders that affect lysosomal degradative enzymes within neurons result in the accumulation of substrate of the deficient enzyme in the neurons. The subsequent enlargement of these neuronal cell bodies is the basis for the term storage disease. In this leukodystrophy, the lack of galactosylceramidase results in the accumulation of psychosine, galactosylsphingosine, which is toxic to oligodendrocytes and Schwann cells and causes a primary demyelination. Neurons appear normal. The globoid cells are the macrophages that are filled with phagocytized myelin remnants. Figure 10-66. Clinical signs first occur between 3 and 7 months of age and may begin as a T3 to L3 spinal cord disorder, as in puppy, and progress to cervical spinal cord and cerebellar clinical signs, or the first clinical signs may reflect cerebellar dysfunction that then progresses to clinical signs of spinal cord involvement. Following the discovery of the gene mutation in children with Krabbe disease, the same gene mutation was found in these 2 breeds of dogs that have a similar disorder. A PCR test is now available for testing blood leukocytes for this gene mutation. It not only confirms the diagnosis in an affected patient but also determines carrier animals, which will help prevent further propagation of the disease. This test was performed on puppy's blood, and it confirmed the diagnosis of globoid cell leukodystrophy. This disease will slowly progress over many months and ultimately result in recumbency, dementia, blindness, and death by 1 to 2 years of age. Puppy was euthanized, and an autopsy revealed the characteristic lesions of this inherited disorder. Neck discomfort case example 10-25 signalment. A 7.5-year-old spayed female Dalmatian, squirt chief complained. Discomfort history. Many weeks of episodes of discomfort, especially with any movement of her neck examination. Video 10-49 shows the partially flexed posture of the neck rigidity, and occasionally holding the right thoracic limb off the ground while standing. This last aspect is referred to as a root signature. In this instance, this term connotes involvement of the nerve roots to the thoracic limb that are irritated, resulting in the expression of pain, but it is also seen with intervertebral disc extrusions located at a more cranial cervical level. This root signature is not specific, as similar clinical signs may result from disorders involving the spinal nerve or nerve itself. The gait is normal, as are the postural reactions and spinal reflexes. Anatomic diagnosis, most likely C6 to T2 spinal cord meninges, spinal nerve roots, or both, spinal nerves, or possibly a more cranial cervical level. Consideration should also be given to discomfort related to vertebral lesions such as osteoarthritis or the cervical musculature. Differential diagnosis, cervical intervertebral disc extrusion protrusion, cervical vertebral disc spondylitis, cervical vertebral neoplasia, meningitis, intracranial neoplasia. Squirts history and clinical signs are most typical of an intervertebral disc extrusion protrusion. The components of the intervertebral disc are not innervated, but the perichondrium that covers the annulus fibrosus and the adjacent periosteum and meninges are innervated and are the source of discomfort when they are disrupted or inflamed. Disc spondylitis or neoplasms of the vertebrae may be the cause of extreme discomfort. Meningitis is often overlooked because it is a less common cause of cervical discomfort in small animals. In small ruminants, pigs, and foals, meningitis is most commonly caused by a hematogenic bacterial infection. This is much less common in small animals. The most common cause of meningitis in young dogs is an autoimmune disorder. Occasionally, neck discomfort is related to an intracranial neoplasm that involves the meninges directly or by displacing the brain secondary to brain swelling with or without the development of a cervical spinal cord syrinx. Cervical radiographs of squirt showed a narrowed space for the intervertebral disc between the C5 and C6 vertebral bodies. Refer to the video. Myelography showed an interruption in the contrast medium within the subarachnoid space ventrally at this articulation, supporting the diagnosis of an intervertebral disc extrusion. Video 13-38 to appreciate the difference from Tigger's case. Video 10-50 shows Snoopy, a 6-year-old castrated male beagle with a chief complaint of neck pain. For the past 10 days Snoopy has held his head down, flexed, and stiff without turning his head and neck and crying out with any movement of his neck. Figure 10-67. Snoopy has a history of an intervertebral disc extrusion, which occurred at T133 years ago, resulting in paraplegia. Following a hemilaminectomy, he recovered normal gait over 2 to 3 weeks. During his entire examination, Snoopy held his neck flexed and any movement resulted in his crying out. Additionally, Snoopy episodically held the right thoracic limb flexed and elevated off the ground. Palpable and visual spontaneous spasms of the caudal ventral cervical musculature were noted. When his name was called, Snoopy looked up but never turned his head and neck. This is referred to as weather vanning, as lateral flexion of the neck was absent when Snoopy moved. This neck rigidity is indicative of the source of the discomfort. His gait was normal, as were the postural reactions, spinal reflexes, and cranial nerves. The anatomic diagnosis was most likely at the C6, T2 spinal cord meninges, spinal nerve roots, or both, nerves, or possibly a more cranial cervical level. Snoopy's differential diagnosis is the same as that for case example 10-24. MRI revealed an extrusion of the intervertebral disc at C5, C6 with compression of the overlying dural sac and neural structures. Snoopy had a ventral slot surgical procedure for removal of the extruded intervertebral disc and made a complete recovery. Canine meningeal polyarteritis, autoimmune meningitis, immune-mediated meningitis, steroid-responsive meningitis arteritis, beagle pain syndrome, sterile meningitis of boxers, necrotizing meningeal arteritis, and canine juvenile polyarteritis syndrome are all names for the same non-infectious disorder, which is the most common cause of meningitis in young dogs, usually younger than 2 years. It is more common in the larger breeds. Boxers and Bernese Mountain dogs are especially at risk. It is also a problem in large colonies of beagles used in research laboratories. A sudden onset of extreme discomfort is the most common clinical sign. As a rule, no neurologic deficits are present, but these patients are commonly depressed and usually have a fever. They have an appearance similar to that of squirt seen in Video 10-49. The discomfort is manifested by extreme reluctance to move, neck rigidity, a short-strided and stiff gait, and uncontrollable screaming when handled. As the CNS parenchyma becomes involved, the clinical signs reflect the segmental area affected by the lesion. This is more common in dogs that have a protracted course, with repeated episodes of the disorder. The meningeal lesion is an extensive suppurative leptomeningitis associated with severe arteritis and fibrinoid necrosis of the arterial wall. Subarachnoid hemorrhage is common in this lesion. Spinal cord meninges are more severely affected than the brain meninges. Similar arterial lesions are occasionally seen in the thyroid, heart, and mediastinum. We have seen one 2-year-old Labrador retriever with an acute onset of paraplegia and analgesia caudal to the mid-thoracic level that had this meningeal polyarteritis and a focal subarachnoid hemorrhage that severely compressed the cranial thoracic spinal cord. Figures 10-68 through 10-72. A blood count usually shows leukocytosis with neutrophilia. CSF clearly reflects this lesion in marked elevation of protein and leukocytes, mostly neutrophils, hundreds to thousands of neutrophils per cubic millimeter. These neutrophils are non-degenerate. Xanthochromia in CSF is common. No infectious agents have been isolated from CSF. IgA is elevated in both serum and CSF, which supports a primary immune-mediated meningeal disorder. The cause of the immune system dysregulation is unknown. In some dogs, these clinical signs may resolve spontaneously after 2 to 11 days of discomfort and fever. However, these clinical signs commonly recur after a variable period of a few days to months. Most dogs respond well to immunosuppressive levels of corticosteroid therapy, which often has to be continued by alternate day therapy to avoid recurrence of the clinical signs. A less severe, protracted form occurs in dogs with repeated episodes of this disorder. Occasionally, juvenile dogs with immune-mediated polyarthritis also have meningeal polyarteritis. Bacterial meningitis is uncommon in small animals. As a rule, infection with rickettsial, bacterial, and fungal agents is bloodborne and involves the meninges prior to invading the parenchyma. None of these microorganisms has a specific predilection for the nervous system. The possible exception to this is Cryptococcus neoformans and coccidioides immitis, which may affect the CNS without systemic involvement. Lethargy, discomfort, and fever are the most common clinical signs prior to involvement of the parenchyma. CSF pleocytosis is usually neutrophilic, but it is often difficult to culture the infectious agent from the CSF. MRI may reveal meningeal enhancement.